This 5-minute presentation will discuss upper GI bleed. Specifically, we will cover how an upper GI bleed presents and the most common causes, as well as highlight some of the key points in management. An upper GI bleed is defined as bleeding in the GI tract proximal to the ligament of Treitz. Patients who present with an upper GI bleed may have melena, which is black or tarry stools, hematemesis, which is bloody emesis, or coffee ground emesis, which resembles coffee grounds due to digestion of blood in the stomach. This can help differentiate an upper GI bleed from a lower GI bleed, where patients may present with hematochezia or blood in the stool, which may be with or without blood clots. 80% of upper GI bleeds are due to 4 different causes: peptic ulcer disease, esophageal varices, esophagitis, and Mallory-Weiss tear, which is a mucosal laceration often due to recurrent retching. The approach to management of an upper GI bleed is best divided into variceal and non-variceal bleeds. This is because the management of upper GI bleed due to esophageal varices is different than the management of other upper GI bleeds. Variceal bleeds, or bleeds due to esophageal varices in the setting of portal hypertension from cirrhosis of the liver, are managed with octreotide, which may help reduce portal blood flow via splanchnic vasoconstriction, antibiotics, which are usually ceftriaxone, and this is given to reduce the risk of a condition called spontaneous bacterial peritonitis in patients with cirrhosis, and IV proton pump inhibitor until peptic ulcer disease is ruled out. Non-variceal bleeds, which include upper GI bleeds from sources like peptic ulcer disease, esophagitis, and Mallory-Weiss tear, are managed with IV proton pump inhibitor, which reduces the risks of rebleeding in peptic ulcer disease. In addition to the above specific treatments, all patients with upper GI bleed, regardless of the source, should be treated with the following: packed red blood cell transfusions to reach the patient's hemoglobin target, which is usually 70, hold anticoagulation and consider reversing depending on the clinical scenario, call GI for endoscopy, which ideally should be performed within 12 hours, and keep the patient NPO. This can be remembered by the mnemonic, blood is red. In conclusion, the management of upper GI bleed can be thought as variceal and non-variceal bleeding, which can help us to remember the unique aspects of treatment. All patients with upper GI bleed should receive IV proton pump inhibitor and a GI consult for consideration of endoscopy.